Okay, would you please tell us about the design and results of active trial?
Sure. The active trial is a trial looking at a new generation cobalt chromium iliac balloon expandable stent. The stent's manufactured by Medtronic, and the trial was meant to look at the population requiring iliac stenting either in the common or the external iliac. It's a single-arm study with a primary safety endpoint of major adverse outcomes at 9 months, including TLR, and then also efficacy outcome of binary restenosis, TLR, and so on. The trial is unique in the sense that it was the first of a next-generation device. The trial was interesting in that it showed very, very low rates of restenosis. Actually, there was only one target lesion revascularization in the trial, and that was relatively early in the trial. At 9 months, there were no other target lesion revascularizations. There were no safety events, and overall, as compared to prior trials, which is difficult to do because the populations are different and so on, but in general, it compares very favorably to trials using both self-expanding and other balloon expandable stents.
So what is the clinical implication of this trial, in your opinion?
Well, I think that it sets a nice standard for endovascular approaches to iliac disease. Today, iliac disease is largely treated endovascularly. The gold standard used to be the aortobifemoral or aortofemoral fem-fem bypass. But I think the active trial really, with restenosis rates of less than 1%, compares extremely favorably to surgery. And like I said, I think answers the question once and for all, whether or not the endovascular approach is a reasonable one for iliac disease.
And would you explain to the audience about the differences between CREST trial and several mega trials like SPACE and ICSS?
In the world of carotid stent trials, there are really 4 mega trials, 3 of them done outside the United States, EVA3S, SPACE, and ICSS, and then the CREST trial. And the problem is that there's been differences in the outcomes between surgery and stenting in these trials, and I think it's reasonable to explore why that might be. And there's probably some easy explanations we should investigate. The first is that for 2 of the trials, that is the ICSS and the EVA3S, there's a real issue with operator experience. The operators who were doing endarterectomy in that trial were pretty well experienced. The people who were doing stenting were not very well experienced at all. And we know now, looking back, that the number of patients required to become experienced is much higher, and they didn't come even close to the number they needed to become experienced. So the outcomes in those trials for carotid stenting, based on operators alone, was terrible. Second piece of information that's interesting between the trials is that if you look at the rate of embolic protection use, CREST had a 95% use of embolic protection because it was mandated in the trial. But in ICSS, it was only about 2/3 of patients, not mandated. In SPACE, it was only 27% of patients. And EVA3S, they mandated it after 80 or so patients had already been treated in the carotid stent arm. And by then, already 4 or 5 strokes had occurred. And so basically the trial was over before it started. So I think that embolic protection being used variably among the other trials, 100% in CREST or 95% in CREST, is a big difference. The third difference is, and this is controversial, but it really shouldn't be, the difference in the rate of myocardial infarction surveillance. CREST has, as one of its endpoints, myocardial infarction, as one of the primary endpoints. And it routinely got EKGs, checked enzymes, and the other trials did not do that. So the rates of myocardial infarction were much lower in the other trials. In fact, in SPACE, they were never even reported, not even one. So we don't really know who had a heart attack in those trials because they didn't do routine EKGs and they didn't do routine enzymes. Why is that important? Because if you look at the outcomes for vascular surgery, it doesn't matter whether you're doing stenting or carotid endarterectomy or anything else. If you have a myocardial infarction around the time of surgery, your rate of death is multiples of what it would be if you didn't have a myocardial infarction in the years that follow the surgery. So it's a very important endpoint. So if you look at those 3 things, operator experience was excellent in CREST, embolic protection, which was uniform in CREST, and myocardial infarction as an endpoint, which it was in CREST, and none of the rest of them, then you really have to admit that CREST is probably the only trial that gives us a real clear picture of the comparison between stenting and surgery for carotid disease.
And what should we do to improve the clinical outcomes of carotid stenting? What should we focus on?
Well, there are several things that have been shown to improve clinical outcomes in carotid stenting. Probably the most important one is operator experience. So patients who are treated by first-time operators do worse than patients who are treated by operators with hundreds of procedures under their belts. And that's normal. It's expected in procedural and operative medicine. It's axiomatic that the more you do, the better off you are. That's not unique to carotid stenting. It's the same with endarterectomy and AAAs and everything else. So the first thing is to assure good operator experience, which means you either have to have a proctor with you or somebody experienced next to you as you learn your cases. And it looks like you're going to need about 50 to 100 cases to become an independent operator with good low rates of complication. The second has to do with case selection, and this goes a little bit to operator experience, but selecting the right cases. So if a patient has difficult anatomy for carotid stenting, whether it's tortuosity, calcification, thrombosis, arch anatomy, and so on, endarterectomy is a very good option for that patient, and we should start really thinking about these procedures as complementary. Stroke and death rates are similar between endarterectomy and stenting. That means we should be talking about which procedure is best for which patient. In the vast majority of patients, it's probably going to be equal between the two, and they can choose either one. But for certain patients, endarterectomy will clearly be better, and for certain patients, stenting will clearly be better. And we should start to recognize those and send them to the right path. In that way, we reduce overall complications of both endarterectomy and stenting because we've chosen the right patient for those therapies. And lastly, technologies improvement, that is, embolic protection improvement, stent improvement, and so on, will add even a % difference in reduction of minor stroke. Overall outcomes will improve and become even better and safer. The same, by the way, is true for endarterectomy. We have to find a way to reduce rates of myocardial infarction, which will make that procedure safer as well. I think right now that both procedures are so safe, it's hard to make an improvement, but those are areas where we probably can do a little bit better.